I am honored to be here today to stand in her place. And this is our first event since she's gone, and our first in-person event since COVID has happened. So it's a very special moment for us, the Wynn Foundation. Of course, we do just about everything with a lot of emotion and passion. The Wynn Foundation was founded in 2012 after the passing of my sister, Rishima Wynn, and hence the name. And it was a remarkable thing as I was talking to folks this morning and just kind of telling the story again of how my sister went into the hospital because she thought she had a really bad flu. And that was about 12 in the afternoon. By 12 in the evening or midnight, she had passed away. And it wasn't until, and most of you who know about TTP, the petechia, did I say that right, Doc? Petechia showed up that, you know, someone even knew to test or check for TTP. And because of those series of events, which was very quick, my mom first said, hey, you know, we're going to put out a message to have people support a TTP foundation. See if you can find one out there. And so we didn't find it. And then the next thing my mother said was, all right, well, we'll start one. Which none of us knew what that meant and what it would grow into, but we're very proud that over the past 10 years, we've been able to raise a good amount of money. We've been able to support research here at the University of Penn with financial support. We have given financial support to the University of Alabama and the University of Kansas, and an effort to help find a cure for TTP. And as we go more and more down the rabbit hole, I guess, of TTP, I'm calling it that because over the years, we found that it's not as rare as we think. Most of our patients who are diagnosed with TTP are diagnosed with something else first. And like in the case of my sister, had someone not been able to identify TTP, those folks pass away, and it's because of a heart attack. It's because of a stroke or something else that is seemingly unrelated to TTP. But those of you who are suffering or who are living with TTP know that nothing's unrelated, right? Because many of you who have TTP or are caregivers for folks who have TTP understand that there are lots and lots of coexisting issues, beginning with mental health and going on to other physical ailments, the fogginess, the memory loss, all of those things that most people or some people would think are unrelated, but they are not. And later on today, we'll hear more about that from Dr. McCrae. I want to talk more about the Wynn Foundation. And over the past 10 years, from our start of our first event was a bowling event, which then moved into a gift of life luncheon, which we talked about as a jazz luncheon, all to promote awareness. But then as we grew, we began a support group. And our support group was local and in Pennsauken, New Jersey. We started there, and that was about 2013, 2014. We may have had 5 or 6 folks who came out. And then about 2019, as we began to expand and find out there were more and more people across the country who needed support, we began experimenting with Zoom. And of course, when the pandemic hit, we were full out, right? So now we can have sometimes up to 100 people in the support group who express their feelings of depression or different things that they're going with. And we're happy to really be able to support them in that way. And this is the first time that we're doing a hybrid event since we're coming back now from COVID, and we're able to have folks here in person, which we love, and then also to able to share with folks on Zoom and wherever you may be, right, in the world, so that you can all participate. So today is about education. It's about building awareness. And over the past 10 years, it's what the Wynn Foundation has been about. Of course, we'd like to provide hope to folks who are living with TTP. We support them in ways that we feel like will be meaningful and provide the type of caring atmosphere that they need so that they know that they're not alone. We advocate for them by partnering with other organizations who can help us push the mission forward to build the awareness in places where we feel we can make a difference, where there can be not just financial support, but also an advocacy so that everyone can be more aware of TTP and these rare diseases. And today we're going to talk about the causes and the consequences of TTP, and hopefully we'll be able to have people have a better understanding of the myriad of issues that coincide with TTP, that coexist with TTP. But through all of that, we're able to provide you hope that things are going to get better, that there will be healing, that we'll be able to find a cure, that we'll be able to continue to support places like the University of Penn, which we're very grateful for them partnering with us today to help us to share the message, and University of Alabama, as well as the University of Kansas, and other universities and medical research centers throughout the world who focus on TTP. This is a very important issue, something that's very near and dear to my heart. So it brings me joy, honor, and then also there's just a little bit of sadness because this is the first time that I'm doing something like this without my mom, who I used to joke about. She's my boss and my mom. So it's like, if I don't do it, I gotta do it, right? So there was a kind of double whammy there when it came to her giving her directive and her gentle but insistent way, right? So that's a good way to put it. She was very gentle, but you knew when she said it, she meant it, right? And you had to get it done. So we're happy to do this, and we're going to move along in the program. We have a video for you to share. It's a number of our patients who have come through the support group over the year, talks a little bit about how they got TTP and what they've done and how they're living with it and coping with it now. So thank you all again for coming out, and we appreciate your time here, and we're going to show the video now.
It happened, I can tell you the day, it was July 27th, 2017. I had been feeling for a few days very, very tired and very, very out of it. I had no energy. And my wife had wanted me to go to the hospital. I had just come from the hospital a few days before with an infection, and I was feeling terrible, and I wasn't really getting any better. I was feeling worse. And then the morning of the day that I ended up going back to the hospital, I had noticed what I now know to be petechia and purpura all over my body. My urine was rust-colored and not normal, and that was a bit alarming. And those two things really were the impetus for me to finally go back to the emergency room. And that started the weeks-long chain of events that happened afterwards. But that's when I first sort of experienced TTP.
It was August of 2019. We had left a party and came home, and he had a stroke. That was stroke number 8. They couldn't seem to stop the strokes. Even with stroke medication, he just kept stroking right through the medicine. So when we went to the hospital, his neurologist at that time, Dr. Ngala, she suggested that, we go to Penn, and they transferred him right to Penn. And still, we were there about a week before they figured out that that's what it was, that he had TTP.
When they did finally diagnose me with the TTP, we started getting different treatments there. And like I said, that's when we found out the diagnosis with this rare blood disorder. So that's when we found out about this TTP thing, because I have never heard about TTP.
TTP in the summer of 2004. I'm getting my years mixed up. 2004, I was a sophomore music major sitting in theory class, and all of a sudden I started feeling bad and having sharp pains in my stomach as I was being stabbed. I called my parents to let them know that I was not feeling well. Let my instructor know that I wasn't feeling well, and I was excused for the day. At the time, I was 19 years old, and so I went home to be with my parents because I wasn't feeling well. I woke up the next morning, had blood clots inside of my mouth, called the family doctor, and immediately got seen and had my labs drawn. And he told me that I'm not going to say that you have cancer, but your lab results mimic my daughter who has leukemia. And so I'm going to call her doctor at the Montgomery Cancer Center and get you over to be seen by him. At that time, the doctor that he was referring to was on vacation, and I saw one of his partners over at the cancer center who was also a hematologist and oncologist. And I was told that I had ITP. So I was actually misdiagnosed at first, given steroids, 100 milligrams of steroids, and sent home and said I will be fine in a few days. Now, I told him that my family, we take a vacation every year to go visit my dad's family in Detroit. So I went on to vacation with my family. During that time, while we was on vacation, I was having episodes. I didn't know who nobody was. I didn't know my family. I didn't know where I was. And it's just started deteriorating. We actually drove to Detroit, and we went on to Canada, still having these deteriorating feelings, not knowing who I was or where I was, and vomiting, diarrhea, and drove all the way back to Alabama. This continued to go on for the next few days, and we went over to Montgomery Cancer Center again, and Dr. Davidson was in, and that's when he actually told me that I had TTP and that I needed to get to UAB Hospital to get plasmas exchanges.
I'm going to share with you how TTP altered my life's journey in 2018. It was the new year, and I was like, new year, new me, and that's literally what happened. In January of 2018, I began to experience symptoms of bruising, severe headaches with numbness on one side from head to toe, heavy menstrual periods, and severe fatigue. So I went to my primary care doctor. He did some labs, and I received a call. My platelets were 34,000. So over the next 2 months, I was in and out the hospital, emergency room, and hematologist office because my symptoms continued to worsen. My hematologist at the time couldn't find out why my platelets were decreasing. So he continued to run tests. He sent me for a bone marrow biopsy. The following week, I was in his office to receive the results of the biopsy. I remember it like it was yesterday. I was very ill that day. The hematologist told me my biopsy was normal, but in fact, it was not normal. It showed some key components of TTP. My platelets had dropped to 13,000, and my hematologist misdiagnosed me with idiopathic thrombocytopenic purpura, also known as ITP. I remember crying to him that day, begging him to admit me to the hospital. I felt like I was dying and that my low platelets are related to my severe headaches. He looked at me and laughed and said, no, it doesn't. And it's not related. And he wouldn't even admit his wife. So he decided to start me on rituximab the following day. So the day after I received my rituximab, it was a Friday, I became deathly ill. I had severe abdominal pain and my urine like a black cherry color, and I was barely responsive. My mother was out of town, and she called my sister and told her to stop what she was doing and go to the house, call 911, and get me to the emergency room. I was admitted to the hospital and waiting to be moved to a room. The on-call hematologist came in and told my mother he had looked over my medical history and he suspected TTP. So he ordered labs and had a vascular team come in and put in my emergency catheter in my leg. He stated they have to move fast. I only had about 12 hours to live. I started plasmapheresis later that night.
Okay, my first experience with TTP was in November of 2000. I was on the west coast of Florida on a weekend vacation, and I was just about to board a dinner cruise with my husband when he came back from the bar with our drinks, and he noticed that I couldn't speak. I was just stuck in like frozen, and no words would come out. My left side was like frozen, and he just looked at me and said, "I'm calling 911." And luckily, I did not get on the boat. So the ambulance came. I really thought I was having a stroke. They took me to the hospital. Now, this is not where I live, so it was a hospital out of town. And it was Thanksgiving weekend, so there weren't many people on hand. They did a couple of blood tests, but they really weren't coming up with anything. So he said, "I'm going to put you in the back of the car and I'm going to take you home and we're going to go to the hospital there." So we drove back across the alley to the Fort Lauderdale, where I was from. And I went to a place called the Cleveland Clinic, which was a teaching hospital, a very good hospital. And after many tests, blood tests, bone marrow tests, all kinds of invasive tests, they came up with the diagnosis of TTP, which nobody had ever heard of before, including me.
Hard and not understanding things, what was going on, what was taking place. And I don't know, it was just a very dramatic experience for me that I never encountered before. I was just, but like I said, like Kanisha did say, but when we got to UPenn, when we got there like 10 o'clock that night, and Dr. Zucker was the first doctor we saw, and he kind of reassured us. He said, he grabbed Kanisha's hand. He said, "Kanisha, we're going to get you better." And that was just so reassuring just to hear those words from him, because it was like a roller coaster, up and down, up and down. One day it was a good report. Next day the numbers dropped, and then numbers go up, and it was just back and forth, and we didn't know what was happening. But yeah, it was very dramatic, and I could say it was a difference in, I don't know, we just was praying and everything would work its way out, and that's what we just kept our faith, and that's what it was like.
Many people with TTP will experience things like maybe they don't feel like they have the same endurance, things like that. I do feel that maybe I'm not 100% like I used to be, but I'm thankful, that I'm alive. I'm grateful for that. I didn't go into any real detail, but I was in the hospital for weeks and I had a really bad time of TTP. So I had the classic pentat. I had all 5 of those symptoms. I ended up having 2 mini strokes, 2 seizures. I was in a coma for a while. I wasn't expected to live. So to come out of it at all, I'm grateful. And I don't think I have maybe quite the same focus, maybe quite the same mental stamina. You make adjustments, but I'm happy to be alive and I'm happy to be in the shape I'm in. So I can't complain.
I have my aches and pains, and actually it's more the headaches. but I feel a lot better. But like I said, you know, I have my aches and pains each and every day. Sometimes it's like one day everything's okay. I don't feel anything. The next day, next 2 days, I might not feel too good. I'm just taking it day at a time. You know, just take my medication and everything like I'm supposed to. And but actually, right now I've been feeling okay, especially compared to a couple of years ago when we first found out what was going on. But I feel a whole lot better, and especially dealing with my doctor, Dr. Sukkar. So, you know, I'm really comfortable with him. And like I said, actually working with him, I do feel a lot better.
At that time, while sitting there, with him talking to me, I started experiencing numbness on my left side. My mother was trying to talk to me, and I could not respond to her. And he was telling us that, you know, I can hear him, but I could not respond because he said that the TTP was having little small blood clots to form in small veins in my brain and stuff that was deteriorating that I need to get to a UAB as fast as I could. And so in the midst of them getting ready to transfer me to UAB, I collapsed. And I don't remember anything after that for 3 days while I was in UAB hospital. While I was at UAB hospital in 2004, I received about 38 plasma exchanges, 4 weeks of rituximab, and 3 infusions of vincristine. So time went on. I was doing well, having a little small setbacks and having to go get just plasmas infused to me. Bring up the speed to 2010, I had another major setback with the TTP. At that time, I was put on Gengraph for a while. Time progressed on. I was doing fine with the Gengraph, just experienced some mild blood pressure issue from the effects of taking Gengraph. And in 2014, I had a major relapse where the Gengraph just completely stopped working. Nothing was working, no plasma infusion. And so I had to be put into an induced coma to make sure my body recovered itself and receive plasma exchanges, rituximab, and back on the steroids. Since then, I have been on maintenance rituximab every 8 weeks, and I'm currently on steroids every other day as a maintenance treatment. And all has been well, and I've been living and enjoying life and back to normal routine. But then also in 2014, I also received outpatient pheresis during that time until my body was able to adjust to just receiving the steroids and the rituximab infusion. And so here I am today with the help of UAB and my hematologist to get me on track and where I can live and enjoy and work while living with TTP.
I spent many nights hiked up off of prednisone researching about TTP. I read stories of survivor caregivers. As I began to research TTP, what I learned was it was rare and there was little information about this disease. That was the moment I made a pact with the Most High God that if he got me out the valley of the shadow of death, I would advocate and spread awareness any way I can for TTP. I began to share my story on Instagram and Facebook, and I did some TTP hashtags. I have met many survivors and caregivers. We are bonded. I would like to tell them that we are family. Even though we're not related bloodline, we're related by blood. I also found the Wynn Foundation. Miss Vicky is an earth angel for TTP survivors. She doesn't want other families to feel the pain her family has felt because of this deadly disease. I am grateful for the healing experience. It has strengthened my faith. Even though I walk through the valley of the shadow of death, I will fear no evil. For thy are with me, your rod and your staff comfort me. Psalms 23:4. I made it through the valley, and I am a TTP survivor and an advocate. TTP really means trust the process.
you can explain it to people, but they don't get it. Your family or friends, I mean, they're sympathetic to your illness or whatever, but nobody really understands what you go through. It's not just being sick, and it's not a sickness where you hurt or you're in pain. It's more of, it's like a PTSD kind of thing. You know, you're always afraid of your relapses. You're always afraid that this is going to be the last one. When I was diagnosed in 2000, they told me I would only live 10 more years. And that's kind of like the sentence that they gave me. And in 2010, I had a particularly bad relapse where the doctors came in and said nothing was working. The treatments weren't working. Get your affairs in order. Talk to your children. It's just not working. Basically, it was 10 years. And I thought, damn, these people are good. 10 years and I'm out of here. I feel like every day is a gift that I've doubled my expectations of years. The thing that gives me hope is the research and the knowledge and the changing. Like I said, Rituxan wasn't even available the first 5 years. I don't remember the name of the chemo they gave me, but it was a harsher chemo. It was hair loss chemo. And now Rituxan is readily used in TTP. And it's not a harmful hair loss kind of chemo. But the things that give me hope are that I've survived this long, and my kids and my grandkids, every day I wake up and I'm thankful that I have another day with grandkids. And I just hope that I live to see them graduate.
So I've had Dr. Zucker still to this day, and his team are still by my side. So I don't have no doubt when it comes to the TTP part, because anytime I feel like, okay, something doesn't feel right, or I feel like, if I'm feeling a little sick or something, I'm able to call and immediately get some scripts for lab work to just make sure that everything is okay. A TTP has been stable since my first relapse. And I think, I've had downfalls here and there, but I will say, it's nothing like the first time. And I think through the whole time, it's been progress on how to handle, living with the TTP. It has affected my life and my mental state. But, if you continue to talk about it, tell your story, and just continue to, let people know what you're experiencing and going through, it's, you make a difference for someone else and be able to help.
It was an honor. We wanted to do something to support patients and families that were experiencing this life-threatening disorder. So we started the Wynn Foundation. We established the Wynn Foundation with the goal to provide hope for those suffering with the disorder, to offer support to families and survivors, and to advocate and to give to research to impact the future of those living with TTP.
I hope everyone enjoyed that video, and I hope it resonates with some folks. I feel like it would, and I hope if you're unfamiliar with TTP, you now have a better understanding. This morning, when I started off, I should have introduced someone who was the first medical professional that the Wynn Foundation engaged, and the person that kind of helped us to frame out what the foundation would look like and introduced us to clients, and really has been a friend and a support for our foundation as well. And that is Dr. Adam Zucker. He helped us put this all together today. So if you're in person, it's all right to applaud. If you're on Zoom, hit the clap button. There should be a clap button or something on there. Make sure you all hit that for Dr. Suker, and I'm going to invite him to say a few words right now. And also did some work at Temple University, just up Broad Street, if many of you know where that is, right? But currently he's working at the Cleveland Clinic, and not only works with patients, but he's in several groups. I'll call them groups. You'll give me the technical term when you come up, that focuses on hematology and other areas, but specifically benign hematology is his focus, in which if anyone out there has a young person or an older person who is interested in going into the medical field, please encourage them to go into hematology. It is a very rewarding field, right? And you can be an expert very quickly in that field, I'm told. So encourage more hematologists. But Dr. McCrae, with no further delay, come on up. Thank you.
Well, thank you. Thank you, James, for that really nice introduction. And thank you to the Wynn Foundation for helping me to be here today, and to Dr. Suker for the invitation. It's really a real great pleasure to be here and to talk about TTP with all of you. The video was I found quite sobering. Maybe I'm a little bit out of touch in the ivory tower, but to hear some of those stories about misdiagnosis and delayed diagnosis is still frightening, and it just tells us really tells me two things. One is we really do need more education everywhere and everywhere about this devastating disease, especially since more and more effective treatments for this are becoming available, and I think more will in the near future. And also the importance of finding doctors who do really understand it. There's many places that don't really have, smaller places that don't really have physicians who really do much hematology. A lot of oncologists do a little hematology on the side. But anyway, it's great to be here, and hopefully I can tell you something about TTP you don't already know, most of it, to be quite honest. So I'll try to tell you some things we do know, and some things we don't know, and some things that are problems that we really need to think about in the future, and remain problems to this day. So I kind of call this the winding TTP journey, and I'll talk a little bit about some of the clinical manifestations, which many of you are probably already familiar with. I know that James got some feedback on what people wanted to hear about, so I have a little bit on the brain in TTP, because the brain is an organ that's importantly very much affected by TTP. And then I'll talk a little bit about what remission of TTP means and what effect TTP may have on long-term outcomes. So here's a little bit of a milestone of TTP. TTP, as I realized when I was doing this, is almost, the discovery of TTP is almost at its 100-year anniversary. So that's something to look forward to and celebrate, I suppose. I guess I'd celebrate how all the bars along this arrow that shows basically things we found out about TTP over the years. We found out in the 1960s that steroids seemed to help, plasma infusion in the late 70s. We found out all about von Willebrand factor. Plasma exchange really became well established, I think, in the late 80s, early 90s. And this dramatically improved outcomes of TTP, at least in initial survival, from 90% fatal to 10% fatal. We've learned about ADAM-TS13, which I'll talk about a little bit, and ADAM-TS13 antibodies. We have rituximab, and now we have caplacizumab, which I think is an important component of treatment, and maybe will become more so. And we found these other things that are still being used newly in TTP that seem to be have promised to be quite beneficial. Now, I think this slide shows I got this from, actually this slide was shared with me by Shruti Chaturvedi, who I'm pleased to say is one of my favorite mentees. She came to me when she was an intern at the Cleveland Clinic and told me she was interested in hematology, but her program director had told her, you know, you can't really make a living in hematology. And I told her otherwise, and she said, okay, well, can we do a project? And I said, sure, let's do something on TTP. And Shruti was brilliant, much smarter than I will ever be. Basically, we did a chart review of TTP patients at Cleveland Clinic. I think we reviewed about 100 patients over a 10-year period and had a nice publication describing that. And you later used that same database to look at some of the longer term consequences as kind of a foundation. But I think that this slide kind of summarizes where we are with this disease. So in the past, just improving survival in TTP was our goal. And we've done a pretty good job of that. Obviously, we're not saving everybody, and that still has room to go. But we've gone from a very, very high fatality rate to a very high survival rate. And at present, I think we're still trying to understand what remission is, what remission means, and how to prevent relapses. I think we'll get there. And then in the future, I think we need to think about treatment as how to mitigate long-term effects of TTP, because we've always had this sort of mindset that is evolving, fortunately, that, you know, TTP is an acute disease, you treat it, you get better. Okay, we did our job. And in fact, even when I trained here at Penn many years ago, we still somewhat thought of TTP this way. But things are changing and changing for the good. Let me talk for just a minute about some of the clinical manifestations and mechanisms. I don't want to spend too long on this because probably you know much of this, but back in the 1940s, paper by Amorosi and Altman described the classical pentad of TTP. You heard one of our patients on the video refer to. And this was fever, thrombocytopenia, of course, which means low platelet count, kidney failure, neurologic findings, and anemia, which we call microangiopathic hemolytic anemia. That just means a type of anemia where the red cells get broken into pieces and you see red cell fragments circulating in the blood. We call these schistocytes. So people would look for this pentad to make a diagnosis of TTP. The problem is by the time you have the whole pentad, TTP is very, very far advanced, and there's been a lot of damage done. So fortunately, probably 20 years ago or more, we realized that simply the microangiopathic hemolytic anemia and thrombocytopenia, low platelets, without any other cause, obvious cause, should be enough to make a diagnosis, a putative diagnosis of TTP. And this is what we go on today, or should go on today. And that's why, you know, when we see an anemia and a thrombocytopenia together, the red flag should go up. We should also have someone looking at the blood under the microscope to see if these schistocytes are there, because that's, when you have that combination, that's all you need. That's all you need to diagnose TTP. Now, what causes TTP? When you read review articles about TTP, this is what the writer usually first goes to. It's a problem with Adam TS13. Over 95% of TTP is what we call immune TTP. That's because you develop antibodies, immune antibodies, against this protein called Adam TS13. There's about 5% or less of TTP that's actually inherited genetically. You have a mutation in your Adam TS13 gene, but I won't talk about that really today. So what happens is your endothelium, as shown here. Now, endothelium are the cells that line your blood vessels. All of your blood vessels are lined with endothelium. And endothelium does things to keep your blood from clotting. If we were to reach into a blood vessel and strip away all your endothelium, that blood vessel would form a blood clot right away. But endothelium makes many things that help to regulate whether blood's clotting or not clotting. And one of the things endothelium makes is this long, large protein called von Willebrand factor. It's a very, very big protein that circulates in the blood, and it aggregates with each other. So many von Willebrand factor molecules kind of stick together. In fact, if you grow endothelial cells in a dish, which you can do in the laboratory, and you look at them under a microscope and you flow fluid over the endothelial cells and stimulate them with something, you can actually see through the microscope these long strings of von Willebrand factor just kind of floating in the breeze there. And if you happen to run platelets through that same system, you'll see that all the platelets are sticking to the von Willebrand factor right in the dish. And this is what's happening in TTP. Now, why doesn't that happen all the time in the body? It doesn't happen all the time. It's because we have this other protein called ADAMTS13, which you can see here as a pair of scissors. And the role of ADAMTS13 is to take these long strings of von Willebrand factor and cut them into these little pieces. And when you have these little pieces, they can still individually bind to platelets, but you don't have these long strings with multiple platelets stuck to them that clog up blood vessels, particularly small blood vessels, often blood vessels in the brain. So here's what happens when you don't have ADAMTS13, or the activity of your ADAMTS13 is blocked by these antibodies patients with TTP develop. You see, you get these long strings of von Willebrand factor shown in blue, and all the platelets are clumped up in these strings of von Willebrand factor, and these go across blood vessels, as shown here, and block blood flow. And then when the red blood cells flow through here, they get broken into little pieces, they get sheared off. And this is what happens this is a blood smear. When you take a drop of blood from a patient, put it on a glass slide, put it under a microscope, usually what you see are these nice round red blood cells. But in TTP, you see these fragmented schistocytes. And you have to look carefully for them. You know, my criteria, everybody has some schistocytes, we all do. But if I see more than one or more schistocytes in one field of a microscope, and the patient has the right symptoms and blood counts, that is TTP. That's all I need, really, to make that diagnosis. But I've left a lot of things unsaid. As I said, when you read review articles on TTP, what they go to is usually what I just told you. But there are people who have low levels of ADAMTS13. In fact, even after you've had a TTP episode, up to 2/3 of patients never actually get their ADAMTS13 levels up to the normal range. They stay chronically low, but they never get another relapse, or they might. We don't know why some do and some don't. We don't know what causes the first episode of TTP. We just don't know any of those things. Even in people with inherited forms, they're born with low ADAMTS13, they may never have a case of an episode of TTP till later in life or when they become pregnant. So there's so much we don't know there. And this is, I think, a really important area we need to look at in future research. When you come to talks about TTP and someone's asked this question, they usually say, well, it must be a virus or something that causes this. It must, whenever we don't know how to explain something, we haven't say, well, it must be a virus, so, but maybe it is, maybe it's something else, but we don't really know that. So I think that's something we really need to think about. Now let's talk about the brain a little bit in TTP. As I've mentioned, TTP is a disease that involves blood vessels. And blood vessels are everywhere. They are in every organ. They're in your heart, they're in your brain, they're in your pancreas, they're in your kidneys, they're everywhere. So TTP is a multi-system disease that can infect all organs. But of course, your brain is rather important. And you know, when you diminish blood flow or cause damage to the brain, it's particularly problematic. So this is an organ we really need to try to protect in TTP. And what are the symptoms of brain involvement? First of all, about 60% of these have neurologic symptoms at presentation. And you've heard our patients talk about these. They may be very subtle. You know, they may just say, well, you know, he didn't remember to, I don't know, he left his keys in the car when he came home from work, or he forgot to do this, or he just doesn't seem himself. They can be more than that, but you need to have a really low threshold when you ask a patient, do you have any symptoms of, you know, but some of the more common ones are headache, numbness or weakness, confusion, in severe cases, seizures. Strokes in acute TTP are really uncommon. It's often thought they're common. They're not that common, at least in the acute stage. But patients with severe disease can have coma. They can have all kinds of neurologic symptoms. If you look at imaging studies, this is a brain MRI. You can do CT or MRIs. Oftentimes there's no findings, actually, particularly on CT. If you do MRI, you can see sometimes these subtle changes in the brain. This would be called posterior reversible encephalopathy. But over time, these often get better if the TTP is treated right. And their presence doesn't really seem to change the impact of TTP. And honestly, I still think people, when a patient comes in with neurologic symptoms and they probably have TTP, they'll send the patient for a CT scan or an MRI of the brain. I think that's a waste of time. There's nothing much you can find there that's going to make a difference. I mean, I think it's fine to do those imaging studies, but the most important thing is to get the treatment started and get the treatment started yesterday. We try to have a system at our hospital where we get, if somebody's being referred in with TTP, that they really let us know about it. And we have our pheresis people, we admit all TTP patients initially to the ICU. We have the ICU team ready to put lines in. We have the pheresis team ready. We try to get their treatment started as soon as the patient is able to get it, as soon as they get to the hospital. And it doesn't matter what time of night or day it is. This is truly an emergency. And when I hear about patients driving to Canada and back, it's just a shame. Anyway, so let's move on from that and talk about remission. Okay, it's great to be in remission. I heard some of our patients say they were in remission, and that's great. But I think we have to think about remission a little differently than we think about remission in some other diseases, because remission can be qualified, to put it that way. And the reason is there's a significant incidence, as many of you know, of relapses in TTP, up to, you know, maybe 40% in the first year or two after an acute episode. But over the long term, after TTP, there are many things that TTP patients have more than other people in the normal population. So they have a higher incidence of high blood pressure. They have a little bit higher incidence of kidney disease. They have a significantly higher incidence of depression, and they have a higher incidence of stroke. So many of these are vascular in nature. But we can break these down into, when we think of the neurologic effects anyway, and this is much from the Oklahoma registry, different types of neurologic sequelae. Neurocognitive, these are long terms, I'm sorry, but I'll explain them a little more. Neuropsychological, neurovascular, and quality of life that that I'm sure needs no explanation. And I'd like to just point out that, hang on 1 minute, yeah, that as I said, remissions are kind of qualified, and actually just last year, there was an international working group on TTP that was actually chaired by Adam Suker that came up with some new criteria for relapse. And the major finding here, this is an abbreviated outline of that, was the distinguishing of complete ADAM TS13 remission, meaning that your ADAM TS13 level in your blood is completely in the normal range, versus patients who seem to be in remission. They don't have low platelets, they don't have anemia, they don't seem to have acute TTP, but their ADAM TS13 stays low. It's above 20% of normal, but it's not at the lower limit of normal for normal healthy patients. So it's in this gray area. And we call this a partial remission, which makes a lot of sense because it may not be a true full remission. So that's an important guideline, actually. Now, moving back to the types of symptoms, neurocognitive symptoms, and you heard some of our patients talk about this. What are they? They mean like, I keep forgetting where I keep things. I keep forgetting what I've already done. Sometimes I think I must have had a case of TTP and not known it, but but these people probably have it even worse than me, believe me. I make more mistakes than I used to. I can't focus. I have a brain fog. Brain fog, that's a very common term. I'm an accountant. I can't afford to have a brain fog. These are the kind of neurocognitive symptoms patients complain of. And they can be subtle. They're not frank dementia. They're not frank intellectual impairment. They can still function in their work and daily activities. They just have to work harder, and they make more mistakes. They get more frustrated. They can't memorize things as well. And these are just some of the studies from Oklahoma, from Ohio State and London that have quantified this using quantitative tests. Now, we don't really know what causes these problems, to be quite honest. Oklahoma, could it be ischemia? Ischemia means lack of blood flow. If you look in the brains of some of these patients on MRI, you might see MRI changes that suggest chronic ischemia. But those don't always correlate with symptoms. You can see some of those things in patients, older patients, even without TTP. So it's not clear to me that that's the cause. But they do likely play a role. Small vessel ischemic changes, you don't know whether they're ongoing, whether there's leftover from the initial episode. It's really hard to track these. And finally, depression. You heard some of our patients talk about depression, talk about PTSD. And in fact, patients who have had acute episodes of TTP and survived them have a high incidence of this, as I mentioned before. They actually test strongly for a PTSD-like disorder when you give the testing for this. Neurovascular sequelae means blood vessels. There's a lot of blood vessels in the brain. There's evidence of some degree of brain infarction. That means kind of like a mini stroke, and up to 40% of survivors. The correlation with symptoms is not completely clear. We need a lot more data on that. But we know that even in the normal population, these kind of silent strokes can be risk factors for bigger strokes in the future. So let's talk about TTP and stroke for a minute, because patients with TTP, as I've shown here over on the left, do have a significantly higher risk for stroke in the future over the long term, 13.1% versus 2.6%. And the interesting thing to me in particular is that if you look at that, this doesn't correlate with a really low ADAM TS13 level, but it does correlate with a with an ADAM TS13 level. So if you use 70% of normal as a cutoff, and most people would say, you know, a TTP survivor, 70% ADAM TS13, that's pretty good, because when they have acute TTP, by definition, they have less than 10% ADAM TS13. So they've made it all the way back to 70%. But if you break those patients down going forward, those with less than 70% of ADAM TS13 have a 27% stroke incidence. Those with more than 70% almost never have a stroke. ADAM TS13, lower levels of ADAM TS13, even within the normal range, if you take the lowest 25% of those patients, they actually have a higher stroke risk than the other 75%. So this is even independent of TTP. So what do we do about this? I don't know, honestly. Can we treat, should 70% be our target? That would be really difficult. But studies like this put it on the table. They teach us that we need to look at these differently. We need a new frame to look at remission in TTP and what ADAM TS13 levels mean. Finally, these neuropsychological effects. This is depression and PTSD. So in the Oklahoma registry of 61 patients, almost 60% had a positive screen for significant depression. In a Canadian study, US study, almost 80%, and severe in up to almost 40% of patients were left with depression. Now, is this because of the stress of and the uncertainty of having TTP? Is it because of changes that happen to the brain during the TTP episode? We don't know that. We really don't know that. We need to know that. We need to know more about that. And as I said earlier, about a third had positive screens for PTSD. And depression and PTSD were associated with unemployment and poor quality of life. Now, most people do think that that counseling after an episode of TTP can be helpful, and some think that medication can help treat this. Some don't. But I think the important thing is for patients to know about this, for patients to not be afraid to talk about this, for patients to know that this is common, and it's potentially treatable, and treating it may improve their quality of life, which you see here. All these things weigh into your quality of life, your physical functioning, your health, your mental health. These things affect your social functioning, energy and fatigue, bodily pain, but a very high incidence of reduced quality of life in these patients. So these are things we need to understand. I've talked about them a little bit. You know, what leads to the neurologic sequelae of this disease? I think it's obviously something that happened in the brain, but exactly what? Is it just the ischemia? Is it other things? Is it the persistently normal, but you know, not really low ADAM TS13? And how can we prevent these things? That's the important question. There are studies going on now looking at this. This is a study that's still ongoing, trying to look at this. These are done at Minnesota and Ohio State. There may be some other studies open now. And I'm going to put in a spin for Shruti Chaturvedi's study. She's gone on after she left Cleveland Clinic to do much bigger and better things, and is actually one of our national authorities on TTP now. She's doing some great research, particularly with respect to the brain. And she actually has a trial funded by National Institute of Health looking at patients after a TTP episode during annual MRIs of the brain and doing cognitive test function and blood testing over a long period of time. And I think this is going to give us important information about this. Now, one of the requests was talking about new treatments, and the newest treatment to come down the block is caplacizumab, Cablivi. I mentioned before about VWF, von Willebrand factor. That's this long string here that's clumping these platelets, and how ADAM-TS13 cuts that into pieces. But when antibodies to ADAM-TS13, symbolized by the red X there, block it, it can't do that. And you get these big VWF strings with platelets on them that can't be cut up. Now, what Keblevi does is it binds to part of the von Willebrand factor that usually binds the platelets. So it blocks the ability, it doesn't shorten, it doesn't help the von Willebrand factor to get cut into pieces, but it blocks the binding of the platelets to the von Willebrand factor. And so it blocks the ability of these big clumps to form that block blood vessels. Keblevi has been in many studies. It shortens duration of acute TTP episodes. And I think what's particularly intriguing is that I think there's good evidence now, pretty good evidence, that it may decrease mortality in TTP even further in acute TTP. But I think what's really going to be important to find out is what happens if the thing about Keblevi is, our current treatments, plasma exchange, rituximab, steroids, all of those don't really work immediately. Even plasma exchange really takes a few days to start to get things turned around in most patients. But if you could give something that immediately prevents these clots from forming in the blood vessels, like Keblevi, it's possible that you're actually sparing brain damage. I have no evidence for that, but I find it a very intriguing idea, and I think it's something that we need to think about. Now, one of the questions that came was, what about COVID? And I can tell you that if you look in the literature, you can find TTP cases associated with COVID. You can find almost anything associated with COVID. It's common, and when you have something that's really common, and then you have superimposed something rare on top of it, you're going to find some cases. But does COVID itself cause TTP? I don't know. I don't know. This is some literature on COVID vaccination. There's actually a third paper I don't have on here. This first paper was descriptive. It described about 27 patients who developed TTP in association with a COVID vaccination. Time of onset was about 3 to 49 days afterwards, with a mean of 13.4 days after vaccination. It happened with all different vaccines. Patients responded to Plex. The one who wasn't treated actually had inherited TTP. That being said, this other paper is a little newer and I think a little more carefully done. This actually looked at COVID vaccinations in almost 80 patients who had had TTP. They found TTP relapse in only one patient 6 days after vaccination, and 3 others later on, making it a little harder to blame the vaccine when it's 35 to 143 days after. And then they looked in this enormous, they call it the VAERS database, where there's millions and millions of cases of patients immunized, who had got the COVID vaccine. And to make a long story short, they found an overall incidence of TTP in this group. There were 37 cases of 0.195 per million. And TTP, as you know, is a rare disease. In the US population, it's about 1.7 to 3.7 per million. So the incidence in this group after the COVID vaccination was actually much lower than in the general population. And I'm not going to tell you that it's protective against TTP, but I will tell you that there's probably some patients with TTP who get a COVID vaccination and it will kick off a relapse, but that I think is extremely rare. And I don't, in my own opinion, consider it a reason not to get a COVID vaccination. though, that's open for discussion, and it has to do with patient comfort and a whole lot of other factors. So that's all I had to say. And again, thank you so much for this invitation. It's really been an honor, and I'm happy to talk about questions.
Thank you.
Well, that's a very that's a very complex situation. I mean, as you've said, and I mean, first of all, she's really lucky to have somebody like Dr. Zucker looking over her. But TTP, TTP is indeed an autoimmune disease, as is lupus, and we find more and more that there's a lot of overlap in these different autoimmune diseases. And I mean, I don't know all the details on your daughter, obviously, but there's certain genetic predispositions, not genetic cause of immune TTP, but people have certain genes and HLA and so forth that predispose them more to getting lupus. There's been a couple defined for TTP. She may have those, but it is not unusual to get a TTP with lupus. I don't think, I mean, from what I hear, I don't think her TTP caused her lupus necessarily. I think she probably had an underlying predisposition toward developing an autoimmune disease probably all her life, because it was probably has a genetic basis, and to some extent. And then, she got her TTP, but she also got lupus, and it's not a very satisfactory explanation. We do lump sort of those kinds of TTP, we call it sort of secondary TTP rather than primary TTP. We do this in other autoimmune diseases too. And some people say, well, is there really any such thing as a primary, or does everybody have these underlying autoimmune predispositions, and can they get two things? And I'm not sure of the answer to that, but I lean more toward I see definitely people with one autoimmune disease, hematologic disease that overlaps with another. They get ITP. There's people with TTP who subsequently developed ITP. There's people with ITP who subsequently developed TTP. And so I think they travel together. In terms of the ADAM TS13 levels, I think there's not really a true standard of care in when to give rituximab in somebody who's asymptomatic, or at least not in an acute TTP episode. I think many people, it's definitely been shown that giving rituximab preemptively in somebody whose ADAM TS13 levels are down in the 20% range or lower is effective in warding off subsequent episodes of acute TTP. I do that. One thing I didn't mention in my talk that actually may be very important is some recent study. There's a paper in Press from the US TMA group but it's been alluded to in reports over the years that African American patients respond much less well to rituximab, particularly in relapses. In fact, rituximab was not, in this TMA registry, was not helpful in prolonging relapse-free survival in African American patients, which are disproportionately affected by TTP, particularly females. So has that changed my practice? I don't know. I think about it. I still use rituximab in African American patients, but I don't use it with the same enthusiasm I used to. I mean, I use it with enthusiasm, but I use it with caution, put it that way, and I'm always on the lookout and thinking of other things, we may need to use, maybe cyclosporin or something, some other type of immunosuppression. But your daughter is having to deal with two things, and many of them have some of the same symptoms. It is kind of hard to sort them. Well, with these kinds of things, I try to be a glass half full guy. And Could there be a cure? I think there could be a cure. I do. You know, I think we're really, I just think in medical research, we're actually making a lot of progress in a lot of things that, people want answers quickly and they don't always come quickly. It takes a lot of work, but the amount of knowledge people are gaining in immunology in particular is striking. I mean, when we think of, even as a comparison, think of cancer and people who used to have a sort of a death sentence and now are being treated with immunotherapy to unleash the immune system and getting remissions. By the way, there have been cases of TTP reported in patients getting cancer immunotherapy. But yeah, I mean, I think there could be a cure. It may not be in my career, but I think there is. Should you be worried about your son who has ITP as a child? I wouldn't be excessively worried. I'd focus on the ITP or had ITP. Like I said, there are cases of ITP and TTP, but those, there's very few. So I don't think having had ITP puts him at much greater risk of TTP. But I would, it's something to be aware of. But I wouldn't worry about it. The other is it possible to have a flare of bruise and symptoms, but lab values are normal? Yeah, I mean, it's definitely possible. I mean, bruising is a difficult symptom. It's very nonspecific. And there's a lot of things that can cause bruising beside TTP. If your ADAM TS13s are good and your platelets are good and your hemoglobin's good, I wouldn't really be that worried about a TTP flare just because there's more bruising. I mean, it's not, I'd get the bruising checked out by your hematologist, but I wouldn't necessarily be all that concerned that this is predicting an imminent TTP relapse. Well, learn what TTP is, and that's not just to the patients, that's to the medical community. I guess can I have two? I actually think every patient these days in the medical system needs an advocate. You can be your own advocate if you're savvy enough, but it's hard to be. It's very complicated, and just don't take anything for granted when you're told something. Be a skeptic. It's okay to be a skeptic with your doctor. Okay, it's okay. I mean, if your doctor is thoughtful, they won't be offended. They'll appreciate it. I love it when the patient comes in and challenges me with questions or why do you say this or why do you say that? And I like that. Some doctors may not, but nothing to not do. So that's two or three things, but.
Thank you very much, Dr. McCrae.
Sure, thank you.
All right, so that ends our morning session for the TTP Education Day. Folks who are on Zoom, you're welcome to hang out for the afternoon session, which will be starting in about 5 minutes now. But we're going to allow time here in the room. There's box lunches and drinks that are available. So we'll allow a few minutes for that. And we've already had some folks starting to show up for our 12 o'clock session. Dr. Zucker, would you like to say a few words as before we start our 12 o'clock?
Oh, sure, James. How nice of you to let me have the last word. Thank you. This is such a terrific session. And I want to thank you and the foundation for putting this together, another really valuable event. Want to thank Dr. McCrae very much for traveling from Cleveland to his old stomping grounds in Philadelphia and sharing his expertise and wisdom with us. And of course, I want to thank the attendees, both in person and virtual, for your engagement and all your questions. I think I probably speak for Dr. McCrae and my other colleagues that the most fun part about this work is getting to interact with you and discuss your questions with you. So as James said, you are all invited to remain for Dr. McCrae's talk, which will begin right around noon. And for those who are attending virtually, I believe there may be a different Zoom link, which Fonda has put in the chat. And I will just make a note that this lecture at noon is geared more toward a medical professional audience rather than a lay audience. So again, you're all encouraged to attend, but just wanted to warn you that that some of the jargon may be at a level that you're not used to. Thank you so much again for attending, everybody.